Hello to everyone and welcome back to my channel. My name is Tommy. I'm a human nutrition student and researcher at the university. What I do in this type of videos is to synthesize the classes at the university so then I can explain and teach you the best and most valuable information you need to know. Today we're going to continue the Physiopathology series of videos and we're going to take a look at the organ failures. So let's begin. Hepatic insufficiency. What are the functions of the liver? Detoxification and transformation of substances, synthesis of proteins, lipoproteins and coagulation factors, storage of glycogen, iron and vitamins, and metabolism, glycogenolysis and neoglucogenesis. So keeping that in mind, what is the liver cirrhosis? Hepatic, chronic, diffuse and irreversible disease. The cirrhosis is a fibrosis, a strangulation, plus regeneration nodules. As you can see, there we have a normal liver and a liver with cirrhosis. All of these are regeneration nodules. The consequences of the cirrhosis are hepatic insufficiency and portal hypertension. The hepatic insufficiency can be acute due to intoxications, which last less than a month, or chronic due to liver cirrhosis indeed, and it lasts for months and years. The signs are affecting the functions of the liver. Detoxification is lowered, therefore feminization, because we cannot detox from, for example, xenoestrogens. Lower albumin synthesis, therefore edemas. Lower synthesis of coagulation factors, so hemorrhages. Lower storage of glycogen, therefore hypoglycemia. And lower bilirubin elimination, jaundice, which we're going to say in a bit. Lower ammonia elimination, which causes encephalopathy. All liver functions are affected, causing hypoalbuminemia, hypogonadism, coagulopathy, jaundice, and hepatic encephalopathy. The portal hypertension, on the other hand, is a high hydrostatic pressure in the portal system. The portal system usually has a portal calvert gradient of 2 to 5 millimeters of mercurium, so it's very easy to access the cavern from the portal one. We don't need that much pressure. The blood seeks to reach the heart because there is a strangulation of the vessels and capillaries. So the blood goes through the esophageal ducts and also through the foveal vein of the liver. It reaches also the umbilicus and goes up to the heart through the skin. And it also goes to the rectum without passing through the liver, therefore causing hemorrhoids. The consequences of this are hypersplenism, ascites, edemas, and cholesterol circulation, hemorrhoids and esophageal varices, as well as hepatic encephalopathy. So now let's take a look at jaundice or icterus. It is the excess of bilirubin, and bilirubin causes a yellowing of skin and mucous membranes. The importance of it often occurs in neonates because of the red blood cell change. They go from the fetal hemoglobin to the adult hemoglobin. Therefore, there is a destruction of hemoglobin and a production of bilirubin. The treatment to remove the excess of bilirubin is using UV light, and this changes the indirect bilirubin to the direct bilirubin, because the indirect is the toxic one and can damage the neonatal brain. Now let's take a look at the physiopathology. So the macrophages and monocytes trap and hydrolyze the red blood cells when they are old. The heme group, though, inside of the hemoglobin cannot be recycled, and we have to modify it inside the monocyte. So as you can see here, red blood cells, the heme group inside the monocyte gets converted into biliverdin. The biliverdin gets converted into bilirubin, which is an indirect bilirubin, the toxic one, and insoluble. The indirect bilirubin travels with albumin to reach the liver. Here it is bound to the glucuronic acid to create the direct bilirubin, the conjugated one, which is secreted through the bile duct and reaches the intestine. Here the bacterial action creates the urobilinogen. 80% of urobilinogen is converted into stercobilin, which gives the feces the brown color. 15% of it goes to the enterohepatic cycling, and 5% of it is reabsorbed into the blood and excreted by the kidneys as urobilin, which gives urine the yellow color. Keeping that in mind, we have a classification. So pre-hepatic, hepatic and post-hepatic jaundice. The cause of the pre-hepatic is the hemolysis or the situation in the newborns. In the hepatic is the hepatitis, and in the post-hepatic is the biliary calculus or pancreatic cancer. What accumulates in the pre-hepatic is the indirect bilirubin, because there is a lot of hemolysis and indeed the creation of bilirubin from the heme group. In the hepatic, both indirect and direct, and in the post-hepatic, the direct bilirubin is the one accumulated. Coluria, which means darkening of the color of the urines because of urobilin. In the prehepatic, no, because we don't have the direct one to create the urobilinogen to then create the urobilin. In the hepatic, yes, there is, variable though. And in the post-hepatic, yes, very much, because indeed we accumulate direct bilirubin that gets converted into urobilinogen and then to urobilin. Urine urobilinogen in the prehepatic is high, in the hepatic is variable, and in the post-hepatic is decreased. And now let's take a look at pancreatitis. So it is an inflammation of the pancreas. Itis means inflammation. It is on the rise due to obesity and gallstones. The etiology, the 70% of it comes from gallstones. It is an obstruction of the choledochopancreatic duct, and it is more frequent in women. But we can also have alcohol as an etiology. 30% of the cases. Only 5% of alcoholics, though, develop it. It is more often in men. All the causes are tobacco, high triglycerides, radiography, we're using radiation, drugs, and idiopathic. In the chronic pancreatitis, 50% of the causes are due to alcohol. Classification, we have the mid-acute, when there is only pain, moderate acute, organ involvement, and the severe acute, 20% of organ damage. As you can see here, if we have a gallstone, it stops the pancreatic enzymes to reach the duodenum, and they will act on the pancreas itself, causing an inflammation, and the pancreas digests itself. In the clinic, it is a persistent severe abdominal pain with dyspnea due to the pleural effusion or respiratory distress, because these enzymes, the pancreatic enzymes, can also affect other tissues around. The diagnosis, we see an increased amylase, increased lipase, which are the pancreatic enzymes, higher PCR, protein C reactive, interleukin-6, and the tumor necrosis factor. We can also check with imaging studies of ultrasounds, CT or MRI. In the chronic pancreatitis, chronic abdominal pain, steatorrhea, fat in feces, pancreatic insufficiency, and visible damage on imaging studies. Complications! 75% are mild, with mortality less than 5%. 20% are severe, with a higher mortality but still less than 40%. The treatment is using serotherapy plus an analgesia. Absolute diet, then oral, and if it's not available, enteral, and if it's not available, parenteral. Antibiotics if the infection is confirmed. In the chronic one, we have to quit smoking and alcohol, and we have to use the pancreatic enzyme replacement therapy. Now let's take a look at acute renal failure. Kidney unable to perform its functions for some hours or days. That's why it's acute. Kidney's functions are elimination of many of the body's waste products, maintaining a constant and normal internal environment, and the synthesis of various important substances, renin, erythropoietin, and 1,25-dihydroxycholecalciferol, aka vitamin D3. This is how the nephron works. We have the renal capsule, which is meant for filtration, the proximal convoluted tubule used for reabsorption and secretion, it is vital to have this one, the loop of Henle used for the solution concentration, reabsorbing water and salts, the distal convoluted tubule, and the collecting duct, used again for reabsorption and the secretion. If we follow a diet with 0.8 grams of protein per kilogram per day, chances are we will have a lower risk of developing renal insufficiency. The diagnosis: in the blood we can see the creatinine, which assesses the renal function, and the urea, which assesses the dehydration. In the urine analysis, we check for creatinine, urine volume, pH, ions and sediments. And in the case of the acute tubular necrosis, it is necrotic desquamated cells. Then here we have the concept of fractional excretion of sodium. It is the urinary and plasma sodium divided by the urinary and plasma creatinine per 100. The interpretation is that if it is less than 1, the value, sodium is being saved, and we have pre-renal problems. If it is more than 3, we have a renal or parenchymatose problem. And between 1 and 3, both can occur. So now let's take a look at the types of acute renal failure. We have the pre-renal, due to decreased renal perfusion, or the post-renal or obstructive, obstruction to urine drainage. And we have also the intrarenal or parenchymal. Vascular involvement, low flow. Glomerular involvement, glomerulus is ruptured. and interstitial involvement, which is very frequent. The 95% of the cases is because of this, renal ischemia or nephrotoxics, causing acute tubular necrosis. This necrosis has two phases: the oligonuric phase, which has low urine, and the polyuric phase, when there is high urine. In the oligonuric, the consequences are sodium and water retention, higher potassium, phosphorus, uric acid, creating acidosis and plasma creatinine increase, and the urine diluted with low creatinine and low osmolarity. In the polyuric phase, again we said we have a high urine, and it appears after 2 to 3 weeks. We have a progressive recovery of renal function and the possibility of dehydration and water electrolyte disorders. Here I created a table that summarizes this even better. So the sodium in the urine, it's low in the pre-renal, high in the acute tubular necrosis, and low in the post-renal. The creatinine in the blood is always the same, high in the 3 cases. The creatinine in the urine, though, is lower in the pre-renal, lower in the acute tubular necrosis, but high in the post-renal. The urine osmolarity is high in the pre-renal, low in the acute tubular necrosis, and low in the post-renal. The sediments in the urine are normal in the pre-renal and pathological in the acute tubular necrosis and post-renal. The consequences of the acute renal failure are oligonuria, azotemia, sodium and water retention, hyperkalemia, hyperphosphatemia, hypoerythemia, and acidosis. Okay, so now let's take a look at toxic hepatitis. It can be caused by paracetamol because of the substance, the NAPK, which is toxic, damages the hepatocytes. 10 grams causes hepatitis and 15 grams is fatal. The glutathione counteracts this toxicity, but alcohol decreases the glutathione, so the damage can start with only 4 grams. The N-acetylcysteine, on the other hand, increases the glutathione. By alcohol metabolism is from ethanol to acetaldehyde to acetoacetic acid and to acetyl-CoA to then create energy or fat. NADH-NAD ratio imbalance, the acetyl-CoA goes to the fat, creates a fatty liver, and high lactic acid, acidification. There's also the production of free radicals, and the acetaldehyde damages the intracellular proteins, higher collagen synthesis, and cancer. The phases of alcoholic liver disease are the steatosis, the fat accumulation because of this, the inflammation, hepatitis, fibrosis, destruction of structures because of higher collagen synthesis, and then cirrhosis, the fibers choke the hepatocytes, and this creates the cancer. And then viral hepatitis. We have the hepatitis A, which is an RNA virus. It has a fecal oral transmission, it is benign, and it has a lower chronization level. The hepatitis B, it is a DNA virus, sexual parenteral transmission, 5% of chronification. And the hepatitis C, it is an RNA virus with a parenteral transmission and an 80% of chronification. And now let's take a look at chronic kidney disease. So we already seen the functions: eliminate toxins, hormonal function, water electrolyte and pH balance, and the gluconeogenesis. These are the functions of the kidneys and how the nephron works. The pathology. So we have this disease when it is not capable, the kidney, of performing its functions, and it is chronic when it lasts more than 3 months. We have 5 stages of this chronic kidney disease depending on the glomerular filtration rate level. Stage 1, more than 90, normal function with damage. Stage 2, 60 to 89, which is mild. Stage 3, from 30 to 59, which is moderate. Stage 4, from 15 to 29, which is severe. And stage 5, less than 15, which is kidney failure, and we require a dialysis. Normal values of glomerular filtration rate between 100 and 130, with an average of 125. The causes can be local lesions or diffuse lesions, direct or immunological aggression. We have to detect the kidney damage by direct method using a biopsy or indirect using a radiography, for example. What happens here is that the nephrons die, and those that remain hypertrophy, they get bigger to try to compensate. Filtration rate lowers creates uremia, high creatinine and high urea, where almost no nephrons remain. The prognosis of the chronic kidney disease is using albuminuria, so how much albumin there is in the urine. The phases of the chronic kidney disease: the first one is the complete compensation, no symptoms. The second one is the partial compensation, higher load filtered by each nephron, because they get bigger, or lower absorption and higher secretion, polyuria and nocturia, and also the onset of arterial hypertension and anemia. We have the partial tubular compensation and total tubular compensation. In the partial, we have the phosphorus that creates a secondary hyperparathyroidism, increasing the PTH and the hypercalcemia. Then the protons create acidity, ammoniogenesis, bone, and the uric acid lowers the filtration and reabsorption of uric acid, indeed. In the total tubular compensation, sodium, ADH, and PTH are affected. And then we have the uremia period, when there is no vitamin D3 and no erythropoietin creation. There is oliguria, less than 600 milliliters, edemas, arterial hypertension, anemia, pruritus, and osteodystrophy. The use of drugs: we have to decrease the dose as the disease worsens and increase the interval between the doses. And also beware of intoxications with antibiotics, anti-inflammatory drugs, and analgesics. Okay, that's it for this video. I hope you understood everything I said. If you didn't, there is a comment section down below. Remember to download this diagram by clicking the first link in the description. Don't forget to like, subscribe, and share this video to your friends and family. Thank you so much for watching, and I will see you in the next one. Ciao!